Hi, and welcome to Medical Record Documentation, a guide to documenting for medical necessity. Okay, so a little bit about me. My name is Grace Palazzo. I'm a registered nurse. For the past 7 years, I've been working in either appeals and or utilization management, care management. A lot of my focus in utilization was physician education, particularly in documentation and level of care. So why should you listen to what I have to say? Well, I have information that you need. It's that simple. I've audited thousands of medical records. I've appealed thousands of denials. I've done many presentations like this one, as well as work with doctors one-to-one to improve their documentation. And for the purposes of this presentation, I'm going to talk about documentation from an appeals nurse perspective. Now, most of you probably don't know the appeals nurses that work in your hospital, or even in some cases that we exist. But trust me, we know you, because we're the people charged with representing you. You admit patients, evaluate, monitor, and treat them alongside many others. And a lot of energy, resources, and time are part of that process. In the end, we expect the patient's insurance company to pay for those services, and that's how we go on to take care of more patients. But often the insurance company refuses to pay, and often they'll say they're not going to pay because the services were not medically necessary. That's where the appeals nurse comes in. Our job is to write an appeal that justifies the care using the information that's in the medical record. Now, some doctors make that easy, and some not so much, depending on what they've documented or what they haven't. We know the doctors that get a lot of denials, we know the doctors that document poorly, and we know the ones that document really well. Sometimes I can read an H&P and know what doctor wrote it without even seeing their name. That's how well we know you. And an appeals nurse's goal is to win. That's our only goal. It's our sole purpose. It's our job. So you can imagine, we love when that documentation is good. When we know exactly what went on with the patient and the thought process is clear, we can write an appeal that can justify the care that was provided, and we know we're going to win. We know the hospital is going to get paid. On the other hand, when I'm trying to write an appeal and the documentation is poor, or scant, or ambiguous, I'm left trying to interpret what was in the doctor's head. It brings me back to high school when my English lit professor would say something like, "So Grace, what is the author really trying to say here?" Except it's much worse, because there's a lot of money riding on my answer. And sometimes it's hundreds of thousands of dollars. So the importance of good documentation can't be overstated, particularly in the hospital setting where there are so many people involved in the care of our patients across different disciplines, different admissions, even different facilities that are relying on that information in the medical record to be accurate and complete and up to date. That's what supports that quality of care and that continuity of care that we strive for. But maintaining that standard also protects us against lawsuits or future inquiries or denial for reimbursement. Now, I know my own PCP swears she could read a note that she wrote 10 years ago and in reading it know exactly what her thought process was at that time. That's a good goal for all of us to have, right? The focus, though, of our conversation today is communication with our payers. And typically in the hospital setting, it's not going to be treating physicians that communicate with the insurance companies. It's going to be representatives of the hospital from care management, or sometimes it'll be a utilization nurse or someone from that realm. And their job is to justify the admission and care. They have to prove medical necessity for the services. And the evidence to do that is the documentation in the medical record. But sometimes that documentation doesn't justify the admission. So then it becomes a question of, was there lack of medical necessity for the admission, or is the documentation lacking? And oftentimes it's the latter. Now, more often than not, when I'm having trouble figuring out the reasoning behind an admission or certain interventions, the treating physician is able to verbally explain to me their thought process, and it's clear the admission was appropriate. And this should be clear to everyone why that's a problem. Now, when I'm working with physicians, I always try to explain to them that when I'm communicating with the insurance companies, I'm representing them and the care they provided and defending the position that we're entitled to reimbursement for all the hard work and resources that went into the care of that patient. By keeping vital information in their head instead of in the chart, they're sending me into a proverbial gunfight with a butter knife. I'm not exaggerating when I say it's a battle every day to get the insurance companies to fulfill their contractual obligation to reimburse providers for their services. Most look for any excuse not to pay. Now, from an appeals perspective, we're usually trying to justify an admission after the patient is discharged. The chart is often coded and the bill's already dropped. It may be weeks, months. In the case of Medicare, it may be even years before we know if a payment's being denied. And it's too late to fix a documentation issue. That's why I always ask physicians to think in ink. Whatever your thought process, your concerns, your suspicions, document them in real time. This way, if Medicare comes in 3 years later and wants to know why a patient was admitted, why a certain procedure was performed, or why the length of stay was unusual, we don't have to guess because it's all explained right there in the medical record. Let's talk about coding and billing for a minute. And I mean literally a minute because this is not my area of expertise. But I'm sure that's true for most of us, right? When you're involved in patient care, the last thing on your mind is, how is this chart going to be coded? But it's important to know that coders are not clinicians. They're not going to add information to the chart or take information out. They're going to plug the information into a program which is going to kick out diagnosis codes. Now, in many hospitals, there are clinical integrity nurses that can query the doctors in real time to prompt them to improve their documentation, which can help the coders arrive at the right diagnosis. But if the information in the medical record is lacking, coding and billing may be inaccurate, and that's another way that hospitals lose a lot of revenue. A coder I used to work with described this process as garbage in, garbage out, and I think that about sums it up. If an admission is appropriate, the documentation should support it. So maybe you feel documentation is tedious or time-consuming, but really it's just a matter of doing what you would normally do in the course of evaluating and treating your patients, and then taking a few minutes to describe the encounter in the medical record. Or maybe you really don't feel comfortable with the process of documenting. For instance, what should be in the medical record, what's pertinent, what shouldn't be a part of the medical record. And I've seen a lot of crazy stuff that has no business being in a medical record. Clinical guidelines can help improve documentation, and I'm going to talk about that more in the next slide. But what I really want to stress here is the importance of telling the patient's story and how it relates to your decision making as the treating physician. So you really want to talk about the patient's history, presentation, severity, responses to interventions in the ED or an observation. Inadequate responses in those settings are certainly an indication for a higher level of care. And please make sure you document how the patient presented prior to any treatment. For example, I was reviewing an admission note on a withdrawal patient who had a CWA of 8 with almost no alcohol in his system, and his last drink was a few days prior to coming to the hospital. So I asked the doctor if the patient could possibly be managed on observation, and he explained that the patient initially presented with a CWA of 22, and it improved dramatically after receiving IV Ativan. Now, that should have been documented in the medical record, because a patient with the CWA of 8 and a patient with the CWA of 22 are two very different scenarios. History and comorbidity. So you might have different concerns regarding a 40-year-old patient with no medical history that's complaining of chest pain, as opposed to a 70-year-old patient with chest pain that had a cabbage last year. Oh, and by the way, our friend with CWIR of 22 also had a history of withdrawal seizures, which would be another indication for admission, and that wasn't documented either. Failed outpatient treatments are always important to discuss because usually that can be an indication that the patient needs a full admission. Level or intensity of care. If you feel your patient's going to require something like neural checks every hour or vital signs every hour, that patient's most likely going to an ICU level of care or at least an ICR level of care. But you want to document why that patient needs that intensity of service. Likelihood of an adverse event. A patient presenting with an asthma exacerbation may be treated in the ED and observed for a period of time and then discharged. But what if that patient's had multiple ICU admissions and a history of intubations? That's a patient you want to monitor more closely, and those are indications for admission. I always ask physicians to emphasize those criteria that I know per the guidelines we use are going to justify the admissions. I don't do that because I'm trying to interfere or question their judgment, but because I know the insurance companies utilize those same guidelines, and they would be hard-pressed to deny payment when those criteria are conspicuously linked to our clinicians' medical decision-making throughout the medical record. Everything we're discussing here is all part of telling the patient's story and its relation to the course of care. And I use the term telling the patient's story because I'm trying to steer you away from those HMPs and those admission notes that look more like shopping lists. You know, there's a list of symptoms, followed by a list of labs and vital signs, followed by a list of interventions in the ED, and then a plan of care, which is essentially a list of future interventions. The thing is, we should never assume that another person, whether at an insurance company or even in a court of law, is going to look at the same information and reach the same conclusions that you did as a treating physician. Because your thought process and your decision making is unique to your training and your experiences. And I just want to share a quick story to emphasize that point. So once upon a time, I was battling an insurance company over the fact that they had a GYN reviewing all of our admissions for medical necessity. It didn't matter if it was a trauma patient, cardiac patient, ortho patient, peds patient. She was reviewing all of them. And I know this because on the bottom of every denial, it said reviewed by Dr. So-and-so specializing in gynecology. And it seemed to me she was denying a lot of these cases arbitrarily. And I'm not naive. I know the goal is to deny payment. But I also wondered if some of those denials were coming to us because of her lack of understanding or knowledge in particular specialties. One day I brought one of her denials to the admitting physician, who was a cardiologist, and I'll never forget his response. He looked at me and he said, "Grace, is this patient even still alive?" And that was my opportunity to explain to him that if there was a risk of sudden cardiac death for this patient or any other risk, it should have been documented, because this GYN doesn't even think the patient needed to be admitted. So I asked him, what are the risks? How great are they? And why is this risk to this patient greater than the other 3 or 4 patients who came to the ED with chest pain that same night and were treated and released? What's the rationale for this patient to be admitted and stay for 2 days? And that's really the point. Don't leave room for interpretation so some GYN who's never seen your patient can decide on a course of care that wouldn't be appropriate for your patient, and it releases the insurance company from its obligation of payment to the hospital. Clinical guidelines are groups of criteria for different illnesses and conditions that are formatted in a kind of bullet list or menu. And if your patient checks a certain number of criteria from that list, they qualify for a specific level of care. And each guideline has a wide range of criteria, which can include symptoms, labs, history, comorbidities, extent or intensity of service, risk for an adverse event. So all the things that we talked about on the previous slide, essentially. The two widely used guidelines are MCG and Interqual, and this is my very poor example of what a guideline might look like. But you get the idea. My patient comes in with cellulitis, and if he has one or more of these exacerbating factors from this drop-down menu, he qualifies for an inpatient level of care. So he's been on long-term steroids, he's immunocompromised, and he qualifies for an inpatient level of care. Most insurance companies approve or deny care based on either MCG or Interqual guidelines, and that's why hospitals pay hundreds of thousands of dollars for one or the other, and sometimes even both. And while using a guideline doesn't guarantee payment, because they are compiled of peer-reviewed and evidence-based research, they do lend credence to clinical decision-making. And for that same reason, they can help improve both health outcomes and financial outcomes. And that also makes them a great teaching tool. Medicare doesn't necessarily use clinical guidelines in the way the commercial payers do, but I still encourage physicians to keep those guidelines in mind when they're treating patients and documenting in the medical record, and that's for all the reasons we've already discussed. Now, Medicare has its own set of rules, and I guess the most famous one is the 2 midnight rule. And that essentially states that the physician has a reasonable expectation that the patient will require an inpatient hospital stay spanning at least 2 midnights. Now, there are some exceptions to this rule, but the important thing is that you understand that it's not enough to say you expect the patient to be in the hospital for 2 midnights. The clinical data has to support that conclusion. And how we accomplish that is by using all the strategies that we discussed in the previous slide. Medicare also asks, how would the patient's condition, safety, or health be threatened if the patient were not admitted? And here again, we're talking about the risk to the patient, right? So we would address comorbidities, failed outpatient treatment, all the things that we've already discussed in the previous slides. So to summarize, the best strategy is a clearly documented rationale for the admission, for the care, for the procedure, every intervention. Tell the patient's story and tie your medical decision-making into what's going on with that patient. Document with the assumption that your decision is going to be questioned by the patient's insurance, because chances are they will be. And the burden falls on the hospital to justify the course of care as medically necessary. And there's no such thing as an unbiased jury in this scenario, because the patient's insurance has something to gain by deciding against us. They get to keep more of their money. So this was an actual admission that was denied. This patient was involved in a small kitchen fire, and the documentation on this patient was so scant, I think it was less than a page. And that's when we were still using handwritten notes. So this doctor did document that the patient had a small burn on her arm and a hoarse voice. The rest of the exam was normal, and the plan of care was to admit the patient for observation. So the case manager copied that information and faxed it over to the insurance company, and of course it was denied as not medically necessary. So I brought the case to the treating physician because I wanted to address the lack of information in the medical record and, the reasons for the denial. He was actually really surprised, I mean, he went on about how the patient had an airway injury, needed constant monitoring, he was concerned, they were going to have to intubate this patient. And again, my response was, why didn't you document any of this in the medical record? And this is a doctor that had been working for many years in his field, an excellent doctor with a great reputation. But his mistake was thinking that someone else, in reading his scant notes, would know what his concerns were and come to the same conclusions. And his other mistake was writing admit for observation, because observation is actually an outpatient service. And once the insurance companies see that documentation, they're going to hang us on it. And that brings us to red flag documentation, or things that make you go, So if you're using these phrases or ideas in your documentation, you probably need to do one of two things. First, ask yourself, does this patient really need a full admission? And if the answer to that is yes, then you need to elaborate as to why. Admit for observation, I've already gone over that. Observation is a level of care that's considered outpatient. And I've had many conversations with doctors about this where they're telling me, but I do need to observe this patient. That's why I wrote observation. And I just tell them, please, think of it as a 4-letter word. Say you need to monitor your patient, and then what is the monitoring that needs to be done, and why does it need to be done at an inpatient level of care? No acute distress, hemodynamically stable, resting comfortably, improved in the ED. That's one of my favorites. I'm not saying those things can't be true and your patient still needs to be hospitalized, but you need to explain why. Because when the insurance company sees the patient's not in distress and they're improving in the ED, and then they spend 2 to 3 days in the hospital being worked up, they're going to say, yeah, that's a big fat no. Reproducible chest pain likely non-cardiac, and then the patients are admitted to the cardiac unit while their tropes are being trended and they're waiting for a stress test. You need to explain the rationale behind that, because the insurance company is likely going to say that workup could be done in the ED or maybe on an observation level of care. Calling out your colleagues. Yeah, you guys do this. Dr. So-and-so admitted the patient for pneumonia, but there's nothing on the imaging. I don't know why Dr. Smith admitted this patient. I called down to radiology 3 times and no one answered. So nothing like that needs to be in the medical record. And I don't need to go into that any further. The insurance company probably isn't going to pay for this. I can't believe how often I see this in the medical record. And again, I go back to my first point. If you're writing that, ask yourself if your patient really needs to be in the hospital. Another big one, giving time frames. Plan for CAT or EGD or whatever it is on Monday, but you're writing that on Friday. So the insurance company is going to want to know why your patient needs to hang out in the hospital for 3 days before those things can happen. I could go on, but I think everybody gets the idea. Well, that's the end of our presentation, so thank you so much for attending, and I hope everyone enjoyed it and hopefully learned something.